Hello, ma'am. You may start now.
Okay. Hello, everyone. I'm Dr. Nida Lakhani. First of all, I would like to thank Med Instructors for providing me with this platform so that I can guide the students of passing MRCOG Part 3. I would like to congratulate all those students who have passed their MRCOG Part 2. Now you people are almost there to get the final degree of MRCOG Part 3. The team of Med instructors are going to guide you how to pass MRCG Part 3. Before we go on further, I would like to give a brief introduction about myself. I have done my MBBS and then I further went on to pursue my career in obstetrics and gynecology. I did my FCPS and MR.
Ma'am, we can't hear you.
Okay, am I audible now?
Yes, ma'am.
Okay. Hello, everyone. I'm Dr. Nida Lakhani. I would like to thank Med instructors for providing me this opportunity to help guide the students to pass MRCUG Part 3. I would like to congratulate all those students who have passed MRCUG Part 2. It's really a very tough exam and you guys are almost there. The team of Med instructors are there to guide you to pass MRCUG Part 3. Before we go on further, I would like to give you a brief introduction about myself. I have done my MBBS, then I went on further to pursue my career in obstetrics and gynecology. I did my FCPS, MRCOG, and then I have some special interest in subfertility for which I have done. Hello.
Ma'am, is it med instutors or med instructors? Are these the same?
No, it's Med instructors.
It's Med Instutors, ma'am.
Okay, instructors, okay. Okay. So today's topic. Okay. So the today's topic is tips and tricks to pass MRCUG Part 3. I would like to tell you that before applying for MRCUG Part 3, you should give at least 6 months of preparation time. Just don't go thinking that let's just see how it goes. Don't give it a try. Just be prepared before going for the exam, because you never know that some students might be preparing for the exam for a year, some might be preparing for 6 months, and you might encounter some people who may be preparing for 2 or 3 months. So you have to be good in your preparation so that you can pass the exam. So now, what is the difference between part 2 and part 3? For part 2, as we all know, that you need to know the diagnosis, the investigations, the management, and the epidemiology. But for MRCOG part 3, we have 5 domains. Number 1 is the information gathering. Number 2 is the communication with the patient. Number 3 is communication with the colleagues. Number 4 is patient safety. And number 5 is applied clinical knowledge. In later part of my presentation, I'm going to go into details regarding all these domains. Okay, so what are the rules to study smart? Rule number 1 is training versus repetition. You have all been through the training for MRCOG. Now what you need to do is you need to apply the knowledge you have, for which you need repetition. If you have done about 200 to 300 cases, then during the day of your exam, everything will come naturally to you. So you need to repeat your stations. Rule number 2 is focus on taking small steps day by day. and apply what you learn on real patients. When you look at the domains, there are 14 domains and 14 modules for MRCG Part 3. And each module has quite a lot number of cases, and it might seem daunting to go through them. But if you go step by step, you take baby steps, do one case per day, then gradually build up your stamina. And you can start with one case, then you can go on to 2, 3, 4. But by the last month of your study, you should be doing 10 cases per day. Rule number 3 is approach your goal using one path. Choose any one module and do all the cases related to that module, because the template for that module is the same, and you will be able to perform your task appropriately. But if you go jumping around, like if you're doing teaching, one case of teaching, one case of postpartum care, one case of maternal medicine, you might find it difficult initially. But once you have got the grip of all the modules, then it would be quite easy for you. So rule number 4 is know precisely what you need to do. You should be knowing in detail about all the 5 domains for MRCG Part 3. And in that way, you will be able to perform the task appropriately. Rule number 5 is determine your starting point to identify what you need to do. It may be different for everyone. Some people might have some insight of what to study, how to study, and you need to determine the time period you need to study. Because if some people might be preparing for MRCG Part 3 during their Part 2 preparation as well. So their requirement for time period would be different from those who have no idea how to go about it. So you might get a scenario where some investigations have been given to you and you need to deliver the results. So there are 2 ways of approaching these kind of stations. First is you can just introduce yourself, build up a rapport, and ask the patient whether what information she has about the results of the investigations, and then deliver the results, and then give the diagnosis and address their concerns, gather the information, and then develop a shared plan. It is very important to involve others, like if the patient requires any multidisciplinary team involvement, or if the patient has come through a GP to you, you need to write back to the GP. The other way of approaching the station is that you just introduce yourself, address the patient's concern, gather the information, and then ask the patient what she knows about the results, and then deliver the results and explain the diagnosis, develop a shared plan, and then involve the others. Both the methods are correct of attempting such a station. So why do candidates fail MRCG Part 3? It doesn't matter how many times you get knocked down. All that matters is you get up one more time than you were knocked down. That's the only way to succeed. So, why do you fail? There might be, it is different for everyone. There might be insufficient preparation. Like you have not given enough time of studying. There's lack of thorough revision of clinical guidelines and protocols. I know it's very difficult to go through the whole guidelines. So all you need to do is, I'm pretty sure that everyone has read the guidelines, they have the knowledge, but since this knowledge is very volatile, you need to keep on revising them. It's very important to have a flow charts and all the diagrams with you so that you can have last minute of revision. Then there is failure to practice with mock exams or case scenarios. It is very important that before you go for the exam, at least 2 weeks before the exam or 10 days before the exam, you need to take mock exams. At least 2 to 3 mock exams before the actual exam will prepare you for the final exam. Like I can give you the example, my example. I took 2 mock exams before my final exam, and then I identified my weaknesses, which I was able to rectify in those 2 weeks which were remaining before my final exam. I kept on what mistakes I was making during my exam was that I was forgetting patient safety. I was forgetting communication with colleagues. So this mock exam made me realize that these are the mistakes which I'm making. So I rectified them, and then in my final exam, I did not make the same mistakes. The second reason is poor time management. Many people face difficulty in managing time during the exam's clinical scenarios. The problem usually occurs that the history taking time should not be more than 2.5 minutes or maximum 3 minutes. Many people do history taking, the information gathering for 5-6 minutes. If your information gathering has exceeded 2.5 to 3 minutes, it gives you a clue that you will not be able to finish your station in time because you need to discuss the management also. You can't take up all the time in information gathering. You just need to do the relevant information gathering. Then in labor ward and gynae ward, there is inability to prioritize tasks effectively. So this will all come with practice. The third is communication skills. There is ineffective communication with simulated patients. Like you need to show empathy, sympathy, and confidentiality should be maintained. You should listen to the role player. The role players are there to guide you. No role player will take you to the wrong path. You have to do active listening of the role player. They're going to help you, and they will take you. If you're going in the wrong direction, they will take you towards the right direction. You just have to pick up the clues. Then there is difficulty in conveying complex medical information in a clear and empathetic manner. Many students, they use medical jargons, which should not be used, as the role player or the lay examiner, they are not medical people. So you need to make sure of that. Then clinical judgment. Challenges in applying theoretical knowledge to practical clinical scenarios. I know everyone has very sound knowledge, but when the case scenario comes, you need to apply your knowledge to the clinical scenarios. But with practice, you will be able to do that. Even if you encounter any new station, your mind will be trained in such a manner that you will be able to do that promptly. Then there is a difficulty in making timely and accurate diagnosis. Nervousness and anxiety. This is another factor where candidate might fail. I'm very sure that everybody faces the exam stress, but it is very important to keep your nerves under control, because stress is only going to ruin your performance. There is difficulty in maintaining composure during the assessment. Then there is lack of familiarity with the exam format. You need to know the exam format. Like there are 5 domains that is going to be assessed. So you need to know about that. And familiarity with the structure and requirement of the exam, insufficient practice with objective structured clinical exam format. So we all know that all the students who have passed MRCG Part 2, they have a lot of knowledge. But the problem is that you need to apply that clinical knowledge. Don't let the nerves get the better of you. And some people are unable to demonstrate the core clinical skills. So how to overcome these problems? The only answer is practice, practice, and practice some more. You need to do time management. You need to build your confidence. Be a safe doctor. Know your limitation. You would be an ST5, so you should know that there are certain tasks that you can do, and there are certain things in which you need to involve others. What is the most important thing is the study buddy. You need to have a group of study buddies, at least 3 or 4, because many of the students are working. Most of you might be working in some of the hospitals, so it is very difficult to match the timings with other people. So if you have a group of 3 or 4 people, you can easily make a WhatsApp group, and you can write there, whoever is free, you can study with them. During the course of your preparation, like it happened with me, I started off with one study buddy, then she had some family issues, so she couldn't give the exam. So I was left with no one to study. I had to find another study buddy. So from my experience, I think you should have at least 3 to 4 study buddies, so that in the end you should have people with whom you can study. So now let's talk about the domains. The most important domain is the patient safety, and it is usually assessed in all the 14 stations. When you look at the station, at the top, it's written that this task is going to assess the domains. Usually 3 or 4 domains are assessed, in which patient safety is usually assessed in all of them. So it is very important that you know the role of clinical governance. For all the students who are not trained in UK, they do not know the UK system. So you need to know about the clinical governance and all the UK system. Our course is going to guide you towards that. So if something goes wrong, and for example, you were doing a surgery and something went wrong in the surgery, it is the duty of Condor to provide apology and explanation when care falls short of expected standards. If there is an angry patient, you need to listen to the patient. And if there is any shortcoming from your side, you need to apologize. That's going to calm the patient, and then he or she will be in a position to listen to you better. You should recognize the limit of your clinical ability and refer or call for help appropriately. Topmost is the confidentiality. There might be cases where confidentiality is very essential. For example, in cases of domestic violence, if you do not mention that whatever is going to be discussed is going to be confidential, the role player is not going to open up and is not going to tell you about the domestic violence. So you need to maintain confidentiality. Respect for patient dignity at all times, and respect for patients' religious beliefs and cultural issues. For example, there are patients who are Jehovah Witnesses who do not accept blood and blood products. So whenever you think that the patient might be undergoing surgery, you need to ask whether the patients are okay with receiving blood and blood products or not. And you have to respect their cultural beliefs. Another important thing is safety of prescribing the drugs. Whatever drugs you are prescribing, that should be safe in pregnancy, or if it's a lactating mother, it should be safe during the lactating period. You need to rule out allergies in all the patients. And you need to learn the skill of triage and prioritization. The next domain is communication with patients and families. So, what is most important that you introduce yourself to the patient and ask them how would they like to be addressed. And you need to ask them what are their concerns. You need to do active listening. You need to explain the condition from which the patients are suffering. Need to discuss the investigations and treatment options. You have to give them all the treatment options for that particular condition they're suffering from and tell them the pros and cons of each treatment option. Don't give them your decision, rather, negotiate a plan with them. You need to obtain informed consent, and your ability to inform, engage, and negotiate to make a shared plan for them is very important. Sometimes the patient will keep on insisting for the wrong treatment options. You can't bluntly say that you are wrong or you are choosing the wrong treatment options. You have to negotiate with them in a way that the patient does not lose their autonomy. You need to tell them the pros and cons of the options they wish and the pros and cons of the option which is appropriate for them. They will definitely come to the right treatment option if you have negotiated with them appropriately. You have to choose a non-judgmental approach. So, when the patient is most stressed and vulnerable, your communication is being tested there. Also, there's hardly a need to apologize when asking for a history of smoking or drinking. These are not illegal activities, but merely lifestyle choices. However, if you signpost them, that can also be done. Now, common pitfalls to avoid in communication with patients and families domain. Don't forget to introduce yourself and explain their role. Don't make assumptions about risk-taking behavior. Don't feel awkward or embarrassed about asking questions about their lifestyle. Don't tell the patients what they need. Otherwise, they will feel that they are losing their autonomy. Rather, try to negotiate a plan. Listen to the patient and respect her views. Do active listening. The patient or the role player, they will guide you to the correct way. Don't use unnecessary jargons, abbreviations that the patient does not understand. Give information in chunks, that is, small amount of information, after which you pause and check the patient has understood. If you give a lot of information at one time, the patient might not be able to comprehend it. So that's why it's necessary to give it in chunks and check whether the patient is understanding what you have told them or not. Okay, now communication. A good starting point is breaking the ice by listening to the patient's ideas, concerns, and expectations. Again, pay attention to active listening, show empathy, and appropriate emotional responses. So, how are you going to overcome these communication barriers? Again, practice, practice, and practice with a study buddy. If you cannot find any study buddy, video record yourself talking and then reviewing that and doing self-reflection. Talking in front of the mirror, talking to people who are not from the medical background and explain things in a jargon-free language. Communication with the colleagues. It is very important to to involve your colleagues in the required domains. This is the mistake which I was making in my stations while I was performing my mock exam. It is very easy to remember the communication with colleagues, and it's an easy thing, but you tend to forget. So the ability to communicate with medical, nursing, midwifery colleagues safely at handover via the notes for both inpatients and outpatients, and with colleagues in primary care. For example, if you have got the patient through a GP letter, so you must write back to the GP at the end of your discussion, whatever management plan you have come up with, so that the GP will be following up the patient. So he or she must know what plan of management has been carried on for this patient. It's better to use a structured system of communication for handover, such as the S-bar tool, which is S is the situation, B is the background, A is the assessment, and R is the recommendation, in order to ensure nothing is missed. Writing prescriptions, you might get cases of referral letters, multidisciplinary team letters, discharge summaries, etc. Then there's a station of teaching, the principles of adult learning and giving feedback. There's a set template for teaching which you need to follow. Now, next domain is the information gathering. The information gathering should be crisp, systematic, and to the point. Whatever you are asking from the patient, you should have justification of why you are asking that from the patient. It should be related to your case. And understanding both of what information is needed and how to obtain that information. Use a blend of mainly open and some closed questions. It is always better to ask open-ended question. Your first question in information gathering should be an open question. You can say, "May I know more about your condition?" And the patient is going to tell you half of the information you need to know. Some of the information is usually given in the scenario. You do not need to repeatedly ask that information. You can just mention that I have read in your case notes and whatever the history is in a line. So common pitfalls to avoid in the information gathering domain is wasting time by asking irrelevant questions, asking mainly closed questions. As I mentioned, that you need to ask open-ended questions. And sometimes if you do not get any specific answer, you might need to use closed questions, but it's generally better to avoid them. Repeating the question Not listening to the answers. This should be avoided. Ignoring the cues from the actor. As I said before, the actor or the role player is there to guide you. She will be giving you cues. You just need to do active listening. Applied clinical knowledge. Using clinical knowledge for individualizing treatment and being able to justify decision making in terms of a holistic approach to patient centered care is very important. As we know that all of you are very much knowledgeable, and but it's just that you need to apply that particular knowledge to that particular case. You need to review all the relevant guidelines. You need to have a folder of your flow charts and the diagrams so that you can revise those guidelines and the flow chart in your last 2 weeks of your preparation. Have a reflection on the case managed in terms of, were the investigation requested appropriate? What is the evidence to support my requests? Were the management plans the most up to date? Were there any obvious omissions in information gathering, investigations, or management? Were the most suitable colleagues involved in the woman's care or not? So important pointers from RCOG examiners. There are going to be 14 stations. At each station, you will be given 12 minutes, which would include the 2 minutes reading time. And the overall exam would be 168 minutes in total. There would be no break in between. The station would consist of either a role player station, where there will be 2 people. One would be the role player and the other would be the examiner. There could be a role player station with the lay examiner, in which there would be 3 people there. One would be the role player, another would be the lay examiner, and the third one would be the examiner. And the third type of case would be the structured discussion, in which you will only have an examiner in front of you. There would be no preparatory station. So, what do you do in the first 2 minutes, which you get to read outside your cubicle? These 2 minutes are known as the golden minutes. You need to read the questions very well. Try to understand the question and see what is the aim of the station. Identify which module is it from. Think and come up with a good management plan for the patient. If you still have time, you can start to prepare your answer. You would be given a small notebook along with a pencil. You can write down the important things like name, age, and things like that, which you forget. And mind you, use a new page for each case so that you're not confused while you're reviewing from your notebook. If sometimes it happens that sometimes it happens that there are so many papers and you're unable to finish reading in those 2 minutes. Once you go inside the cubicle, you will have the same papers inside, and you can take time to review those. So, what should your case answer involve? Introduction of yourself, situation awareness, which means that where are you? Are you in a sexual health clinic? Are you in a labor ward? It's very important to be aware of the situation. Then you need to set an agenda. that what are you going to discuss with the patient? What are you going to do with the patient? Then address patient's concerns. This is very important. You need to ask the patient that what are your concerns? Otherwise, you would go through the whole station and you might miss some concern that the patient might. Then you can start your information gathering. That is basically the history taking. It should be crisp and relevant, and it should not exceed 2.5 to 3 minutes. Then if any investigation has been given, you need to do the interpretation and ask the role player what the patient knows about the investigation. And then you can explain that to the role player. Check patient's understanding and then summarize in the end if you have time. The most important thing is provide the role player with the written information. Do not say that I will provide you with patient information leaflet for all the cases, because all the cases do not have patient information leaflets. If you remember and you know that the particular condition has patient information leaflet, you can mention that I will be providing you with patient information leaflet. Otherwise, you can simply say, I will give you some written information. Then you can also talk about support groups and close the session by thanking. How to behave inside the station. Do nothing. Just take a deep breath and forget what happened in the last station. You will still have time to read the question inside the room. Don't rush. If you need more time, then more than a minute to understand the question, you can ask for it. Be confident, but don't try to be cool. Be yourself, but show you are a competent and a safe clinician. You should be dressed up in an attire in which you are comfortable with. Be calm. And even if your last station was a disaster, remember, OSCE tests your attitude and application of your knowledge, not your knowledge. Bad station does not mean that you failed. I will give you my example. I did very badly in one station. It was a structured discussion, and somehow I had not read about that, and I was completely blank in that station. The examiner tried to help me by asking questions in different ways, but I could simply not recall. So that station went totally wrong, and I thought that I will fail my exam. But luckily, my other stations were good, so I finally passed my exam. So the reason for telling you all this is that even if your station went bad, does not mean that you failed. You need to do your best in your next station. Don't think about the previous station. So how to handle the examiners? Do not give attention to examiners in role-playing station. Don't wait for their approval or disapproval. They are instructed not to react to you. Most of the time, they just watch and listen. Don't try to read their facial expressions, as they will not give you any. In structured discussion, don't argue with them. Believe me, they are not there to discourage you or to fail you. They are there to pass you. If you do not know any answer, they will guide you. If you're missing any point, they will guide you. So please don't argue with them. If you didn't hear the question, ask them to repeat it. If you didn't understand, tell them to rephrase it. How to handle the role players. Speak slowly and clearly. Use non-medical language. Maintain eye contact with the patient in a role play station. Avoid looking at the question or at the examiner. Use a standard format for introducing yourself and starting the station. Remember to ask the patient if they have any questions, any concerns. Don't confront or try to correct them. How to handle the lay examiner. The lay examiner station contains the maximum marks, and they are non-medical people. So they are marking you in mainly communication. So completely ignore them. If you handle the role player appropriately, she will pass you. Don't forget, she is not a clinical person, so she is judging you, your attitude, and your communication skills. In the end, I would like to say, if you want to win, you have to be the best in the room. Learn the rules of the game and play it better than everyone. So I would like to end my presentation here. Are there any questions? I hope this session has been informative for you. Am I
Yes,
audible?
ma'am. I have posted a question. Could you please answer my question?
Okay, let me check. Okay, so Mirza wants to know about the resources. The resources basically for the exam is the guideline, the TOG articles, the RCUG guidelines, which you can find on the website. Other than that, the course will provide you with some templates, which is going to help you in preparing for the case scenarios. Is
Ma'am,
there
we
any
have
other
a few
question?
more questions in the chat box.
Mm-hmm. Okay. Yeah, so there's a question like, are there any consideration or policies regarding rescheduling or canceling the MRCG Part 3 exam? Yes, they do have that, but there's a time period before you can do that. If you read the FAQs of MRCG Part 3 exam, you can easily find your answer over there. There's some time period in which you can cancel the exam. Then, are there any specific communication challenges that we can commonly face in MRCUG? Yes. Sometimes students who English, if it is not the mother language, so there are some students who might have difficulty in communicating their thoughts and their answers, but that also can be encountered by watching English movies, by reading books, and you can improve your English skills and by practicing with study buddies. Because while my preparation for MRCUG Part 3, I saw some patients, some students who were not very good in English, yet they passed their exam. So it's doable. And also, sometimes the role player's accent might not be that understandable for some people who are not used to the accents. So these are the challenges which you can face, but usually most of them, they do well. Okay, so then there is a question, can you provide example of scenarios that assesses a candidate's ability to handle emergency? Yes. So there is a station of labor ward which assesses how you can handle emergency, how you can prioritize the emergency cases first, which can be done, and which would be done secondly, and also there's a common scenario, like if you're doing a laparoscopy and you find that you have injured the bowel. This is a common scenario that might come in exam, and that will assess the candidate's ability to assess and how to go forward with this kind of situation. How can candidates request special accommodations for MRCOG Part 3 exam? Again, for that, you need to contact the MRCOG websites. There is FAQs over there. You can read them, and then there is their email address where you can ask any other specific questions you require. Can you provide information on fee associated with booking the MRCOG Part 3 exam? See, the fee structure is a bit different for different countries. It is all mentioned on the website. There is band A, B, and C. So it all depends upon the country where you are located. Are there any recent changes or update to MRCOG-3 exam format or content? No, not as such. Can you please tell which all things and documents to be carried along with me for the exam? For the exam, you only need an ID. Yeah, I think that's all with the questions. Yeah, usually the exam happens in May and I think September. The dates of the exam are mentioned on the website. And the centers, usually London is always the center, and then the other centers are different for different exam dates. That's also mentioned on the website. Do we have any more questions? Okay. So good luck to everyone, and we are looking forward to all the students who will be joining us. We'll try to help you as much as we can. What is now easy for us, we'll try to make it easy for you. Initially, while we were preparing for our exams, it was difficult for us as well. But now once we have prepared for the exam and now we know what to do, we can guide you. You're welcome. Hope this session was useful for you. Welcome, Sarah. Yeah, I hope next session also will be useful for you.
Okay, thank you so much, ma'am, for the wonderful session.
Okay,
Hope to
well,
see you again.
okay, see you.
See you.
Bye.
Bye-bye.
Bye.